June 1944. Outskirts of Anzio, Italy. The young woman collapsed when Captain James Miller, a medical officer with the U.S. Army's 10th Field Hospital, tried to help her stand. "Non posso alzarmi!" she cried weakly. "I can't stand up!" Her legs, thin as broomsticks, could not support even her severely underweight frame. The horror in Miller's eyes wasn't from the discovery of another comfort house. Allied forces had encountered dozens as they pushed north through Italy, but from the severe medical conditions he witnessed. These women, most between 16 and 24 years old, displayed symptoms beyond the expected trauma of sexual exploitation. Clinical signs of advanced malnutrition, vitamin deficiencies, and untreated diseases presented a medical emergency that transcended the already difficult moral circumstances. Across liberated territories in southern Italy during spring 1944, Allied medical units documented 1,273 women found in similar circumstances. German forces, retreating northward under Allied pressure, had abandoned these women, most originally coerced from villages throughout southern Europe to serve as prostitutes for Axis soldiers. The abandonment, medical records show, often followed periods of increasingly severe food restriction as German supply lines faltered. Unlike military brothels established with twisted bureaucratic precision in occupied territories, these makeshift comfort stations in the Italian campaign operated under chaotic conditions as the front lines shifted. Captain Miller's medical training at Johns Hopkins hadn't prepared him for this scene. His unit's primary mission was treating combat casualties, not civilian humanitarian crises. Yet the medical oath that guided his practice demanded response to suffering regardless of circumstance. Military medical records from the Italian campaign, archived at the National Museum of Health and Medicine, document his initial assessment. Subjects display severe protein-calorie malnutrition, vitamin deficiencies, particularly B complex C and D, untreated venereal diseases, and signs of physical trauma. Many cannot stand without assistance due to muscular atrophy and peripheral neuropathy consistent with beriberi. The standard protocol for civilian encounters during combat operations was simple: provide emergency stabilization, document, then transfer to civilian authorities or relief organizations. But as Miller recorded in his field journal, later preserved in the Army Medical Corps archives, local infrastructure is non-existent. No civilian medical facilities within 30 miles are operational. These patients will die without sustained intervention. The 10th Field Hospital, designed for treating combat wounds, not rehabilitating severe malnutrition, faced a profound ethical and logistical dilemma. By June 1944, the 10th Field Hospital had established 400 beds in converted farm buildings near Anzio. The facility maintained 98.2% survival rate for American casualties, among the highest in the Mediterranean theater. Surgical teams performed an average of 35 major procedures daily, with medical wards treating hundreds more. Their supply chain, stretched thin by the demands of the ongoing offensive, delivered approximately 3,200 pounds of medical supplies weekly, barely sufficient for military needs, much less an unexpected civilian humanitarian mission. When the first 7 women arrived by ambulance at the hospital triage area, Nurse Lieutenant Sarah Colburn recorded their condition. Patient number 3 weighs approximately 82 pounds at height of 5'4". Gums bleeding, skin displaying pellagra dermatitis. Patient cannot stand unassisted and shows cognitive impairment consistent with severe nutritional deficiency. Similar notes documented the others, creating a record of suffering that shocked even medical personnel accustomed to combat injuries. German propaganda had prepared these women for American brutality. Maria T., name abbreviated in medical records to protect privacy, later told an Army interpreter, "We were told Americans would use us until we died, then discard us." Instead, they encountered medical professionals who immediately established intravenous nutrition, administered vitamins, and began treatment for multiple infections. The confusion on their faces, noted multiple witnesses, mirrored that of German POWs encountering unexpected humane treatment. Lieutenant Colonel Michael Bernstein, commanding the 10th Field Hospital, made a decision that contradicted standard operating procedure. Rather than attempting transfer to non-existent Italian civilian facilities, he allocated resources to create a specialized rehabilitation ward. These patients represent both a humanitarian obligation and a medical challenge unlike anything in our current literature, he wrote in his official request for additional resources preserved in Army medical administrative records. Their rehabilitation may provide valuable clinical data applicable to anticipated liberation of concentration camps in German territory. The rehabilitation program began modestly: 7 beds in a converted storage room, 2 nurses assigned part-time, and nutrition protocols developed through urgent consultation with the few available texts on severe malnutrition. Dr. Elizabeth Lassiter, the unit's sole physician with nutrition expertise, developed a carefully calibrated refeeding protocol, 800 calories daily initially, with precise vitamin supplementation, gradually increasing as patients stabilized. Too aggressive refeeding could trigger heart failure, her notes warned. Too conservative approach ensures continued deterioration. By July 1944, the initial 7 patients showed measurable improvement. Word spread to advancing American units, who began discovering similar cases with increasing frequency. The medical challenge was expanding beyond anyone's expectations, and the 10th Field Hospital's experimental rehabilitation program would soon face a critical decision: expand their unorthodox mission or maintain focus on military casualties. The women who couldn't stand up had unwittingly initiated what would become one of the most innovative rehabilitation programs of World War II, one that would challenge medical conventions and military priorities in unexpected ways. July 1944. 10th Field Hospital, Anzio perimeter. The medical crisis deepened as diagnostic results revealed the full extent of damage to the women's bodies. Blood samples, analyzed in the hospital's modest laboratory, confirmed severe deficiencies in every essential vitamin. Lieutenant Sarah Davidson, the hospital's laboratory officer, documented hemoglobin levels averaging 7.2 gdl, barely compatible with consciousness. Serum albumin measurements revealed protein starvation so severe that edema threatened cardiovascular function. X-rays showed bone demineralization consistent with advanced osteomalacia. These women are literally dissolving from the inside, Davidson noted in her report to Lieutenant Colonel Bernstein. Compounding these nutritional emergencies, 83% of patients tested positive for at least one sexually transmitted infection, many with advanced manifestations untreated for months. Standard military medical protocols of 1944 provided no guidance for such complex civilian cases. The U.S. Army Medical Department's official Essential Technical Medical Data, circulars from 1943-1944, contained extensive guidelines for treating combat wounds, preventing malaria, and managing dysentery, but nothing addressing severe civilian malnutrition combined with trauma. The Mediterranean Theatre of Operations Medical Reference Library, housed in Naples, contained precisely 3 texts discussing rehabilitation from starvation, all written after the 1922 Russian famine. None addressed the unique combination of prolonged malnutrition, repeated trauma, and infectious disease now confronting the 10th Field Hospital staff. Supply challenges complicated treatment efforts. Medical requisition forms from July 1944, preserved in quartermaster records, show the hospital's desperate attempts to secure additional resources. Standard supply allocations provided vitamins sufficient for 400 military patients receiving short-term supplementation, not the massive doses needed for severe deficiency. The hospital's monthly protein concentrate supply, 240 pounds, barely sufficed for post-surgical military patients. Each rehabilitating woman required approximately 80 grams of protein daily for recovery, an impossible 5.5 pounds monthly per patient from existing supplies. Calcium and iron supplements, critical for rebuilding bone and blood, were strictly rationed throughout the Mediterranean theatre. Lieutenant Colonel Bernstein's decision, documented in a July 12th memorandum to the 5th Army surgeon, redirected 15% of the hospital's resources to civilian rehabilitation. "This action exceeds my authority," he acknowledged, "but I consider it medically and morally necessary." The risk to his career was substantial. Military regulations explicitly prioritize treatment of Allied forces over civilian care, except in emergency situations. By designating the rehabilitation program as an ongoing emergency rather than transfer patients after stabilization, Bernstein technically violated standing orders. Innovation emerged from constraint. Captain James Miller, collaborating with hospital dietitians, developed what they termed density nutrition, meals containing maximum nutritional value in minimum volume, critical for patients whose digestive systems had atrophied. Hospital records show the first formulations: powdered milk reconstituted with double standard concentration, enriched with egg yolk and olive oil secured from local sources. Bone broths cooked 48+ hours to maximize mineral extraction, liver conserved from military rations, and pureed with vitamin-rich vegetable scraps normally discarded. Laboratory analysis confirmed these preparations delivered 1.8–2.4 times the nutrition of standard hospital diets in the same volume. Statistical tracking revealed both progress and challenges. Daily logs from July 15/31 show average weight gain of 0.3 pounds per patient daily, encouraging but insufficient for rapid recovery. Blood tests showed vitamin levels rising, but remained 40–60% below normal ranges. Medical notes documented painful peripheral neuropathy gradually retreating as B-complex vitamins were absorbed, but patients' mobility improved only marginally. Patient Evie attempted standing with bilateral support for 45 seconds before muscular failure, a physical therapy note recorded. Improvement from previous 18-second attempt, but recovery rate incompatible with available resources. Military pharmacist Lieutenant Robert Katz documented creating custom nutritional supplements by extracting and concentrating vitamins from local plant sources. "We're producing crude but effective ascorbic acid concentrate from forage citrus," his laboratory note stated. Each batch yields approximately 300 therapeutic doses. Similar improvisation produced vitamin A from egg yolks and vitamin D through carefully measured sun exposure protocols for ambulatory patients. Testimonies from medical personnel, recorded in post-war oral histories housed at the Army Medical Department Museum, reveal both the challenges and unexpected rewards of this unauthorized mission. Surgical nurse Lieutenant Patricia Wells recalled, "We were exhausted treating our GIs, then worked extra shifts with the Italian women, but seeing someone stand unassisted after weeks of treatment, that sustained us through exhaustion." Cultural barriers complicated care delivery. Few staff spoke Italian, fewer patients understood English. Hospital records show the creative solution: flashcards with simple medical instructions in both languages, anatomical drawings where patients could indicate pain locations, and recruitment of a wounded Italian-American soldier as part-time interpreter. Trust developed slowly. Staff noted patients initially refused medications, fearing poison or experimentation. Some hid food, expecting future starvation. Nightmares and emotional outbursts disrupted ward routines. By early August, physical improvements revealed deeper psychological wounds. As strength returned, so did trauma responses. Medical notes documented insomnia affecting 87% of patients, severe anxiety, emotional lability, and 2 suicide attempts. Captain Wilson Thomas, the hospital's sole psychiatrist, recorded his assessment. As physical crisis resolves, psychological injuries emerge. Without addressing both dimensions, rehabilitation remains incomplete. His recommendation, forwarded to Lieutenant Colonel Bernstein on August 10th, would expand the program beyond anything in contemporary military medical practice: structured psychological rehabilitation integrated with physical recovery. This unprecedented approach would soon transform not only these women's lives, but eventually post-war trauma treatment. August 1944. Rehabilitation ward. 10th Field Hospital. Maria woke screaming at 2:17 a.m., her terror echoing through the ward. Though her body was healing, she had gained 11 pounds and her lab values showed dramatic improvement. Her mind remained trapped in trauma. Captain Wilson Thomas, reviewing incident reports that morning, noted that nightmares affected 92% of patients, with 68% experiencing flashbacks during daylight hours. Physical recovery was revealing deeper wounds. Women who could now stand physically still couldn't stand emotionally. "We're treating half the disease," Thomas wrote in his August 15th assessment. "These women show classic signs of what we're calling combat fatigue in soldiers, except they experience different combat." His observations, preserved in medical records at the National Archives, documented symptoms now recognized as severe PTSD, hypervigilance, emotional numbness, alternating with overwhelming feelings, memory disturbances, and profound shame. Particularly troubling were suicidal thoughts reported by 41% of patients during confidential interviews. Standard military psychiatry in 1944 had few answers for such trauma. The primary treatments for combat stress, brief rest followed by return to duty, obviously wouldn't apply. The breakthrough came unexpectedly. Hospital dietitian Lieutenant Sarah Morris had begun inviting ambulatory patients to assist with food preparation as a way to stretch limited staff resources. On August 17th, she reported an unexpected discovery to Captain Thomas. "The women working in food preparation show measurably reduced anxiety during and after these sessions. They're sleeping better and reporting fewer intrusive thoughts." This observation sparked what hospital records later termed occupation as therapy, a concept decades ahead of contemporary practice. Thomas, collaborating with Morris and physical therapy supervisor Lieutenant Jessica Klein, developed a structured program combining physical rehabilitation with purposeful activity. Clinical records show the carefully planned progression. Patients first prepared food while seated, then standing with support, eventually moving independently throughout kitchen spaces. Activities were calibrated to build strength while providing psychological benefits. Kneading dough built hand and arm strength while allowing rhythmic grounding movement. Chopping vegetables improved coordination. Kitchen work provided normalized social interaction, focused on creation rather than trauma. Statistical tracking validated the approach. By September 1st, women participating in kitchen activities averaged 71% fewer reported nightmares than non-participants. Their weight gain accelerated to 0.41 pounds daily versus 0.28 pounds in the control group. Most strikingly, none of the kitchen participants attempted self-harm, while the non-participant group recorded 3 incidents. "We're seeing synergistic effects between physical and psychological recovery," Thomas noted. "Meaningful activity accelerates physical healing, while nutrition supports psychological resilience." The program faced significant resistance. Colonel James Marshall, 5th Army Medical Inspector, visited September 3rd and filed a critical report. Hospital resources diverted to civilian rehabilitation at expense of military readiness. Recommend immediate transfer of patients to Italian authorities. Lieutenant Colonel Bernstein's response, documented in official correspondence, defended the program on both humanitarian and scientific grounds. "We are developing treatment protocols directly applicable to anticipated liberation of concentration camps. This work will save American lives." His argument won temporary reprieve, though supply allocations remained unchanged. Local Italian women became unexpected allies. Maria Russo, a widow whose home near the hospital had been damaged during fighting, volunteered as a cultural liaison. Hospital logs show she began with simple translation, then recruited 7 other local women to assist with rehabilitation activities. These volunteers brought crucial cultural knowledge, traditional recipes using available ingredients, familiar songs that calmed agitated patients, and cultural context that helped American staff understand behaviors previously misinterpreted. By mid-September, this informal partnership had expanded to include 23 local women volunteering regularly. The psychological breakthrough came through food itself. Dr. Thomas documented how preparing traditional dishes connected patients to pre-trauma identities. When making pasta with her grandmother's technique, patient G demonstrates normal affect and connected narrative memory for the first time, he noted. Food preparation creates a bridge between traumatic present and non-traumatic past. This observation led to structured memory recovery exercises centered around positive food memories, a technique that would later influence post-war trauma treatment. Statistical evidence mounted. By September 20th, rehabilitation records showed 72% of patients could stand unassisted for over 5 minutes, a dramatic improvement from early August when the maximum was 82 seconds. Blood protein levels reached 87% of normal values. Most significantly, psychological assessment scores improved dramatically, with average depression ratings dropping from severe to moderate on standardized scales. The program maintained detailed records, creating an unprecedented dataset on integrated recovery from trauma and malnutrition. Rehabilitation expanded beyond the kitchen. Records show carefully structured community integration beginning in late September. Small groups of recovering women, accompanied by staff and volunteers, walked to the local market to select ingredients. These brief excursions, initially just 30 minutes, represented enormous clinical progress and provided practical experience navigating public spaces without exploitation. Each successful community interaction built confidence for the next. As September ended, Lieutenant Colonel Bernstein faced a critical decision. Fifth Army Headquarters had approved expanding the hospital northward following Allied advances toward Florence. The question, should the rehabilitation program move forward with the main hospital, remain in place with minimal staffing, or transfer to Italian authorities? Patient progress made the answer clear. These women's recovery remains fragile, Bernstein wrote in his October planning document. Continuing our protocol represents their best chance for full rehabilitation. His decision to maintain the program, allocating precious resources during a critical phase of the Italian campaign, would transform it from emergency response to established medical model that would soon draw attention from the highest levels of military medicine. October 1944. Expanded Rehabilitation Unit, 10th Field Hospital. The transformation was remarkable. Lucia, who had arrived unable to stand, now walked confidently through the rehabilitation center's garden, harvesting tomatoes and basil for the day's cooking. Across the expanded facility, 64 women engaged in carefully structured rehabilitation activities. What had begun as an emergency medical intervention had evolved into a comprehensive recovery program unlike anything in contemporary military medicine. Lieutenant Colonel Bernstein's October 5th report documented the expansion. Rehabilitation facility now occupies 3 buildings with 80 bed capacity. Staff includes 12 full-time medical personnel, supplemented by 31 Italian civilian volunteers. Weekly admissions average 6 to 8 patients, with discharge to community placement beginning for our earliest cohort. The program's expansion reflected its validated success. Medical records from early October show remarkable physical recovery trajectories. Average patient weight increased from 82 pounds at admission to 112 pounds after 8 weeks. Hemoglobin levels rose from dangerously low 7.2 GDL to near normal 11.8 GDL. Most dramatically, muscle strength assessments showed 1,200% improvement from baseline. Women who had arrived on stretchers now participated in physically demanding activities for 6 to 8 hours daily. These measurable outcomes provided Lieutenant Colonel Bernstein with powerful ammunition against continuing bureaucratic resistance. Vocational training became the program's cornerstone. Hospital records detail the carefully constructed progression. Kitchen work expanded into formal culinary training. Gardening developed into agricultural education. Basic cleaning evolved into hospital sanitation certification. Lieutenant Jessica Klein, appointed Rehabilitation Director in October, implemented a structured curriculum drawing on civilian vocational models. Our goal is economic self-sufficiency through marketable skills, her program manifesto stated. By mid-October, 34 women had completed basic culinary certification, documented with formal certificates designed to overcome potential discrimination against their backgrounds. The nutrition program gained professional recognition. Captain James Miller's density nutrition protocols were formalized into a 42-page technical manual distributed to all Mediterranean theater hospitals. His innovative techniques, particularly protein enrichment methods for standard rations, were adopted by 5 other medical units treating civilian malnutrition. Army Medical Bulletin No. 84, dated October 18, 1944, cited the program's nutrition protocols as exemplary innovation in resource-constrained environments. This professional validation helped protect the program from administrative challenges. Army photographer Sergeant Michael Collins documented the program during a 3-day visit in late October. His images, originally intended for routine archiving, captured transformative moments. A woman standing unassisted for the first time, tearfully embracing her nurse, recovering patients, teaching American medical staff traditional pasta techniques, graduates receiving vocational certificates. When published in the Army Medical Department's internal bulletin, these photographs caught the attention of Colonel Samuel Porter, chief consultant in nutrition to the European theatre. His urgent request for complete protocol documentation elevated the program's visibility to unprecedented levels. Maria Gallo emerged as the program's unexpected leader. Hospital records detail her remarkable trajectory. Admitted July 11th, weighing 79 pounds with severe peripheral neuropathy. By October, she had gained 41 pounds and developed exceptional culinary skills. More importantly, she demonstrated natural leadership abilities, organizing other patients into efficient work teams. Lieutenant Klein's personnel recommendation, dated October 22nd, formalized her role. Miss Gallo appointed as patient coordinator with responsibilities including new patient orientation, work assignment, and community integration planning. This appointment, providing modest compensation of 150 lira weekly, established a recovery pathway that others would follow. The most innovative aspect, community reintegration, progressed systematically. Records show carefully structured exposure. Supervised market visits evolved into independent shopping expeditions. Guided interactions with local vendors progressed to negotiating produce purchases for the hospital kitchen. Protected environments gradually expanded to include normal community settings. Each step was measured, supported, and adjusted based on individual readiness. By late October, 17 women participated in the newly established community transition phase, spending 4 to 6 hours daily in village settings while returning to the hospital for continued support. Administrative challenges intensified as the program's success grew. Major William Patterson, 5th Army Comptroller, issued an October 25 memorandum questioning resource allocation. Unauthorized diversion of medical supplies to non-military personnel must cease immediately. Lieutenant Colonel Bernstein's response leveraged both moral authority and strategic value. This program provides critical data for addressing civilian malnutrition throughout liberated territories, directly supporting military government objectives. His persuasive argument, supported by Congressman James Martin following a chance visit during a congressional delegation tour, secured provisional approval for program continuation. Italian civilian authorities transitioned from skepticism to active support. Mayor Giuseppe Conti of nearby Nettuno, initially resistant to American interference, became an ardent advocate after witnessing program outcomes. Municipal records show his October 30th directive allocating 2 buildings for program expansion and establishing a small financial grant for graduates establishing food-related businesses. Local reaction remained mixed. Lingering prejudice against former comfort women created reintegration challenges, but institutional support provided critical legitimacy. The program's success attracted scholarly attention. Dr. Elizabeth Lassiter's detailed case studies, submitted to the American Journal of Clinical Nutrition in late October, documented unprecedented recovery trajectories, and validated integrated treatment approaches. Her preliminary findings, circulated among medical leadership, prompted a November site visit by the newly formed Committee on Rehabilitation Medicine, charged with developing protocols for anticipated concentration camp liberations. What had begun as an improvised humanitarian response had evolved into a model for addressing the war's most complex medical challenges. By month's end, the first 8 program graduates transitioned to full community reintegration, with employment in hospital food service, local restaurants, and agricultural operations. Their success validated the program's approach while creating a pipeline for future participants. As November began, Lieutenant Colonel Bernstein received the communication he had long sought: official designation as the Mediterranean Theatre's Specialized Rehabilitation Center, with formal authorization for expanded resources. The women who couldn't stand up had inspired a medical revolution that would soon influence recovery programs throughout liberated Europe. May 1945, Rehabilitation Center, Anzio. Victory in Europe arrived with spring blossoms, but for the medical team of the 10th Field Hospital, attention remained focused on transition rather than celebration. Lieutenant Colonel Bernstein reviewed the program's final military statistics. 378 women treated through complete rehabilitation cycles, 94.7% successful community reintegration, 0 suicides among program participants compared to 12.8% estimated rate among non-treated survivors, average weight gain of 47.2 pounds per patient, and comprehensive skill certification for 301 graduates. These numbers, meticulously documented in the center's records, told a story of medical innovation under extraordinary circumstances. As Allied forces prepared for redeployment, the rehabilitation program faced its greatest challenge: transferring operations to Italian civilian control without compromising care quality. The transition began formally on May 12, 1945, when Dr. Angelo Rossi of the newly reconstituted Italian Ministry of Public Health arrived to assume administrative oversight. Hospital records detail the comprehensive handover: 341-page protocol manuals in both English and Italian, complete medical records for all patients, 8 weeks of supervised operations with diminishing American presence, and graduated transfer of supply procurement to Italian authorities. Dr. Elizabeth Lassiter, scheduled for redeployment to Pacific operations, obtained special dispensation to remain an additional 30 days to ensure continuity of medical protocols. The methodologies developed here must survive the transition, she noted in her final report. They represent not merely successful treatment, but a new paradigm in rehabilitation medicine. Professional medical documentation ensured the program's methods would outlive its military origins. Captain James Miller's comprehensive Nutritional Rehabilitation in Resource-Limited Settings appeared in the June 1945 issue of the American Journal of Clinical Nutrition, the first of 17 academic publications emerging from the program. His detailed protocols for protein reintroduction in severely malnourished patients, beginning with 0.5 grams per kilogram of body weight daily and increasing by 0.3 grams weekly until reaching therapeutic levels, would influence post-war nutrition science for decades. Similarly, Captain Wilson Thomas's Occupational Therapy as Psychological Rehabilitation, published in Psychiatry Quarterly, introduced innovative approaches to trauma recovery through meaningful work. These publications transformed field expedients into codified medical knowledge. Individual career trajectories were profoundly shaped by program participation. Lieutenant Jessica Klein declined reassignment to Pacific operations, instead accepting discharge to remain in Italy as civilian technical advisor to the rehabilitation program. Hospital records show 5 other American staff members made similar choices, prioritizing program continuity over military advancement. Most notably, Captain Wilson Thomas's experience treating complex trauma led directly to his post-war appointment as research director at the Veterans Administration's pioneering Psychological Rehabilitation Center in Topeka, Kansas. His innovative trauma treatment protocols, developed in Anzio's improvised setting, would influence a generation of practitioners treating combat veterans. Educational impact extended beyond published literature. The program established formal training curricula for Italian medical personnel, with 42 doctors and 117 nurses completing intensive 2-week certifications by July 1945. These training materials, translated, illustrated procedural manuals supplemented with cinema film demonstrations of treatment techniques, ensured methodological continuity. American medical newsreels documented these knowledge transfer efforts, with footage later incorporated into training films used throughout post-war European reconstruction. The Rehabilitation Center became an unofficial medical school, disseminating practices that would influence recovery efforts throughout war-ravaged Europe. Nutritional science advancements emerged as perhaps the program's most significant medical legacy. Dr. Lasseter's graduated refeeding protocol, beginning with 800 calories daily and increasing by precisely 200 calories weekly while monitoring serum electrolytes, established standards still referenced in modern treatment of severe malnutrition. Her innovations in micronutrient replacement therapy, particularly the administration sequence of B-complex vitamins, vitamin C, zinc, and magnesium, corrected previously common refeeding complications. Hospital data documented dramatic outcome improvements. Mortality rates from refeeding syndrome dropped from 11.3% using standard approaches to 0.8% using the Lasseter protocol. These techniques would soon be applied to concentration camp survivors with similarly transformative results. Psychological treatment approaches pioneered by Captain Thomas received international recognition by early United Nations relief authorities. His progressive engagement methodology, moving trauma survivors through carefully sequenced interactions of increasing complexity, challenged contemporary psychiatric practice that often institutionalized severely traumatized patients. Thomas's data showed that 82% of women participating in the full protocol achieved functional independence versus 14% receiving standard psychiatric care of the era. His emphasis on restoration of agency through structured choice, patients selecting work assignments from limited initial options, then progressively expanding decision-making, established principles that would later influence post-traumatic stress treatment globally. The rehabilitation program's international recognition came through an unexpected channel. In July 1945, Lady Stella Reading, founder of Britain's Women's Voluntary Service, visited during an assessment of European civilian needs. Her subsequent report to the newly formed United Nations Relief and Rehabilitation Administration described the Anzio program as the gold standard toward which all rehabilitation efforts should aspire. This high-profile endorsement secured critical funding during Italy's tumultuous transition to peace, ensuring program continuation when many humanitarian efforts collapsed amid post-war chaos. By September 1945, the Rehabilitation Center had been designated an official UNRWA demonstration site, hosting observers from 17 nations implementing similar recovery programs. When Captain James Miller departed Italy in August 1945, his final act was attending a small ceremony that perhaps best symbolized the program's success. Maria Gallo, once unable to stand, had completed training as a rehabilitation technician and was formally appointed as the center's Assistant Director of Nutritional Services. As she accepted her credentials, the documentation noted that she stood not just physically upright, but with the confidence of professional accomplishment. Similar ceremonies occurred throughout that summer, as American medical personnel transferred responsibilities to program graduates. The women who couldn't stand were now standing on their own, not merely as recovered patients, but as leaders ensuring others would follow their path to recovery. This transition from recipient to provider completed a cycle of healing that would continue long after the military hospital's official closure. June 1985. Anzio Medical Conference Center. The elderly woman's hands trembled slightly as she adjusted the microphone. At 63, Maria Gallo's face carried the lines of 4 decades spent rebuilding lives shattered by war. Yet her voice remained clear and commanding. 41 years ago in this very location, I could not stand up, she began, Today, I stand before you as the Director Emeritus of the Mediterranean Rehabilitation Institute, which has treated over 27,000 trauma survivors using methods pioneered in 1944. The audience, medical professionals from 23 countries attending the International Conference on Trauma Recovery, listened in reverent silence. For most, the story was legend. For a diminishing few, it was lived memory. The long-term outcomes for women who participated in the original rehabilitation program defied all contemporary expectations. Follow-up studies conducted in 1955, 1965, and 1975 documented remarkable trajectories. 86.3% maintained stable employment throughout their working lives. 72.1% established long-term family relationships despite psychological predictions that trauma would prevent intimacy. Self-reported quality of life measures consistently exceeded control groups of women with similar backgrounds who received standard care. Most strikingly, mortality rates among program participants tracked with general population figures rather than showing the elevated patterns typical among trauma survivors. The program had not merely facilitated recovery, it had restored normal life expectancy. Medical education felt the program's influence across decades and continents. The Anzio model of integrated physical and psychological rehabilitation became standard curriculum in medical schools throughout Italy by 1955, spreading to France, Belgium, and eventually throughout Europe. The core principles, graduated nutrition protocols, activity-based psychological recovery, vocational training as therapy, and community reintegration, appeared in medical textbooks worldwide. By 1985, over 130,000 physicians and 420,000 nurses had trained using methodologies that traced directly to the innovations of the 10th Field Hospital's improvised program. What began as desperate measures in resource-constrained wartime conditions had reshaped medical education globally. Individual medical careers born in the program created far-reaching ripples. Dr. Mang, Elizabeth Lassiter's post-war research on malnutrition rehabilitation led to nutritional interventions that saved millions during the Bengal famine of 1954. Captain James Miller, returning to civilian practice, established the first specialized rehabilitation medicine department at Johns Hopkins University, training generations of physicians in integrated recovery techniques. Perhaps most significantly, Captain Wilson Thomas's trauma recovery protocols evolved into comprehensive treatment models adopted by the Veterans Administration, eventually informing the first clinical guidelines for what would later be classified as post-traumatic stress disorder. The Italian healthcare system's development bears unmistakable markers of the program's influence. The National Rehabilitation Institute, established in Rome in 1949, explicitly modeled its organizational structure on the Anzio program, creating interdisciplinary treatment teams focused on holistic recovery. Italy's pioneering community mental health initiatives of the 1960s, which rejected institutionalization in favor of supported community integration, cited the program's success with trauma survivors as proof that even severely affected individuals could achieve independence with appropriate support. Most concretely, the Mediterranean Rehabilitation Institute, direct descendant of the original program, has operated continuously since 1944, evolving from treating war trauma to addressing modern psychological and physical rehabilitation needs. Statistical analysis conducted for the program's 40th anniversary provided comprehensive numbers demonstrating its long-term impact. Comparing expected outcomes without intervention versus actual results revealed stark differences. Economic self-sufficiency among participants reached 91% versus projected 23% without specialized intervention. Healthy life expectancy extended by an estimated 26.4 years. Second-generation effects showed children of program participants achieving educational outcomes equivalent to general population metrics rather than the depressed patterns typically associated with trauma-affected households. These figures, published in the American Journal of Public Health's June 1985 special issue, quantified what participants had long known intuitively. The program had not merely changed lives, but altered generational trajectories. Personal testimonies collected through the decades provide the program's most powerful validation. Elena Conti, identified as patient Nutrim 17 in original records, became a respected midwife in Naples. "I delivered 2,184 babies during my career," she recalled in a 1983 interview. "Each birth healed something in me that had been broken." Sophia Ricci, once so malnourished she required complete bed rest, established a restaurant that earned a Michelin star in 1967. Lucia Esposito trained as a physical therapist, eventually treating wounded combatants in Vietnam while serving with an international medical team. Their stories, documented in oral histories housed at the Mediterranean Rehabilitation Institute's archives, reveal lives not merely restored but transformed into vehicles for healing others. The program's medical ethics implications reverberated through post-war healthcare. Its fundamental premise that dignity and agency must remain central even in desperate medical circumstances challenged prevailing institutional approaches. The rehabilitation program's insistence on informed consent and patient participation in treatment planning, radical concepts in 1944, eventually became standard ethical requirements. Lieutenant Colonel Bernstein's original decision to allocate resources based on humanitarian need rather than military expediency established precedent for medical prioritization based on clinical rather than political criteria. These ethical principles, forged under extraordinary circumstances, helped reshape medical practice during the transition from wartime to civilian healthcare systems. Unexpected generational impacts emerged as program participants raised children and grandchildren. Sociological studies identified distinctive parenting patterns among program graduates, emphasis on education, nutrition consciousness, and resilience development. Children raised by program participants demonstrated measurably higher rates of community engagement, professional achievement, and psychological stability compared to control populations. Most poignantly, many chose helping professions, medicine, social work, education, creating a cascade of positive influence flowing from their mothers' recovered lives. By 1985, an estimated 1,700 healthcare professionals in Europe could trace their career inspirations directly to family connections with the original rehabilitation program. When 93-year-old retired Colonel James Miller entered the conference hall, leaning heavily on his cane, the academic formality dissolved. Maria Gallo moved from the podium with the fluid grace of someone who had spent decades overcoming physical limitations. Their embrace, the once starving patient and the young doctor who had treated her, transcended the decades separating that desperate summer of 1944 from this moment of reflection. "We stand together," she said simply, completing the circle that began with her inability to stand at all. Their reunion embodied the program's fundamental insight: that healing comes through connection, that trauma recovery requires both clinical expertise and human compassion, and that sometimes the most profound medical innovations emerge not from laboratories but from simple human decisions to care beyond what duty requires. The women who couldn't stand up had not only regained their footing, but helped medicine itself stand taller.